What's going to happen after this is Dr. Treon will take questions, and we're going to run mics around to you because there's not a good place to set them up. So Sue, would you mind doing that? Or one of them? And Michael, would you mind running the other one around? Okay. Okay. Good afternoon. My name is Carl Harrington, and before I introduce Dr. Treon, who doesn't actually need an introduction, for our first ever live broadcast of a presentation from an IWMF Ed Forum, I want to give you a little background about some other firsts in Philadelphia. Now, there's a park over by the Delaware River that's got a bunch of plaques. It talks about firsts in Philadelphia. So Philadelphia was not only the first planned city in North America and the site of the Declaration of Independence, it was also the first public library, the first hospital, the first railroad, the first mint, the first stock exchange, the first escalator, the first business school, the first fully air-conditioned building, the first zoo, the first outdoor market, which is the Italian market, the first computer, the longest continually inhabited street in America, which you could go there while you're here, the first museum, the first art institute, the first American flag, the first stamp, first locomotive, the first car, the first root beer, the first mustard, the first free public school, the first volunteer fire company, the first U.S. zoo, and about a zillion other things. But I bet you they're going to put a plaque up over there after this because it's going to be the first time the IWMF had a live presentation anytime in the world today, and that's going to go on that plaque. So it's my pleasure to introduce a man who does not need any introduction, but our deepest thanks, Dr. Steve Treon from the Dana-Farber Cancer Institute. Dr. Treon.
Good afternoon, and thank you so much, Carl, for that very kind introduction. Before I get started, I too also want to acknowledge the president and trustees of the IWMF, as well as the attentive and very caring staff of the IWMF. And if you're able, please stand up and let's give them a very loud round of applause. We have an enormous amount of debt that we owe these individuals for all their hard work and support of everything that helps make all this progress possible. And over the next hour, we're going to be reviewing some of the important breakthroughs that have occurred. So the ones that I'm actually going to talk about are the ones that were reported at the International Waldenstroms Workshop, which occurred in New York City. That was last fall. This was an incredible meeting, and I have to thank my colleague Chris Patterson, who served as the secretariat for the meeting. If Chris could please stand up and also be acknowledged for all his hard work. This was the 10th International Workshop. We had 350 investigators representing 35 countries that came to New York to be able to present their research. And a lot was learned, and I'm going to be able to try to summarize all that in less than an hour's time. You can see where the challenge is. But the second important meeting occurred in New York, this time in April of this year, and this was the roadmap meeting that's sponsored between the IWMF and the Leukemia and Lymphoma Society. This too was, I think, a very special meeting because it brought together world experts. This was a two-day summit where we had the opportunity to be able to get into the nitty-gritty of what had been discussed at the workshop, and through this meeting to be able to develop a strategy that we hope would help us get to the finish line. And so in the next hour, we're going to actually go through some of the questions that represent the priorities of our field and try to go a little bit through the research that has been done and needs to be done to be able to get us those answers. Now, as you're going to see, we're going to do a deep dive here. And my hope is that by the time we're done an hour from now, that we will all still be together. You will have, obviously, the opportunity to ask lots of questions once we're done. And so I'm very excited to be able to share this information with you. So let's go through question number one. You see these questions, I think it really challenges all of us in this room, whether you're here as a patient, as a caregiver, as a doctor, as a scientist. These are all the questions that should make us all think about where we are and where we need to go. So here is the first provocative question. Why are complete responses so uncommon in Waldenstroms even with targeted therapy? And I just want you to reflect on this, because to me this is probably the most fundamental of all questions, that if we really hope one day to cure this disease, and I'm certain we will, first we have to get complete remissions. Because if we're not able to get folks there, really the endeavor of finding a cure becomes a challenge. And just to frame this controversy before I get into the data as to why this still remains an elusive objective, consider the debate that exists among our colleagues. That being, should we really be striving for complete remissions, or should we be striving for control of disease? And this is a very important paradox, because this means that the efforts, that we're putting into this disease, should they be focused on being able to annihilate every Waldenstroms cell that a patient has, or should they be focused on trying to control the disease? And there are a lot of variables that go into how one prioritizes these two very important questions. So as I go through, I just want to show you, first of all, why Waldenstroms has this challenge. First off, when you look at the bone marrow of a patient with Waldenstroms, be privy to the fact that it's not really one type of cell that we're going after. These are cells that are able to differentiate. They're able to morph. And as a result, the therapies that perhaps target one type of cell don't necessarily target the other. And many of you are familiar with the term lymphoplasmacytic lymphoma. After all, if you got a bone marrow biopsy, that's what you're going to see. You're not going to see the word Waldenstroms macroglobulinemia. You're going to see lymphoplasmacytic lymphoma. This is what the World Health Organization definition is of Waldenstroms. And what that means is there's lymphocytes, much like the ones we see in lymphoma, but there's also plasma cells, much like we see in the disease multiple myeloma. And here we are now looking at this bone marrow biopsy, and you can see these cell types. Here's a B cell, this rounded cell right here that we see. This cell actually has CD20, and I think everybody in this room knows what CD20 is. This is the target of Rituxan, right? And then you've got this intermediary cell called the lymphoplasmacytic cell, and it's one of those cells that actually has features of both a B cell and a plasma cell, and it too also has CD20 on it, the target of Rituxan. But now you go to the other cell that we see in the bone marrow, and that's the plasma cell. So if you had multiple myeloma, this would be the only cell that you would see. If you had lymphoma, this would be the only cell you could see. But look at what this cell doesn't have. It doesn't have CD20. So the target of Rituxan is not on this cell. So now you begin to see that if you're going to be using a drug like Rituxan, you're going to get part of the clone, but you're going to end up missing, another part. And if you want to guess where IgM is made, it's largely in this plasma cell. So if you have some problem attached to the IgM, this is the cell that you really want to go after. And as a result, just using a drug like rituximab alone may not get you there. And so that's really important to keep in mind. Now, this is actually framing the state of the art. These are all the drugs and drug combinations that we use with rituximab. If we use rituximab alone, we usually get responses somewhere between 25 and 40% of patients, but that second column here shows you the complete remission response rate. And what you're seeing there is 0 to 5%. And what you're also seeing right next to it is the time that we're able to control the disease just with Rituxan alone. And that's somewhere between 13 months outwards to 22 months based on the published literature. So it tells us that, we're not really getting deep or very sustained responses in most patients. And this is why the field over the last 20 years has tried to build on Rituxan as a backbone. And this is not unique to Waldenstroms. We've done the same thing with all the other B-cell malignancies with, I think, varying degrees of success. And so a lot of the drugs that we've combined rituximab were meant to not only help hit those B cells even harder, but go after those plasma cells that the Rituxan doesn't touch. And that's why some of the more popular regimens that you see down here, the proteasome inhibitors, that would be like a drug like Velcade, bortezomib, or carfilzomib, as well as bendamustine, those are the drugs that have shown really the greatest promise in combining with rituximab. And note here that the response rates that we've been able to get with these combinations have been up to 90%, but we're also seeing more complete remissions. But notice once again, 5 to 20% of patients in a complete remission. I think everyone in this room would agree we can do better. And that's really the point of all this. And when you look at what that means, those deeper responses, you begin to see that that translates into being able to keep patients in a remission for a longer period of time. Now, this slide here represented a study that I did back in 2011. It was published in the British Journal of Hematology. And what it was meant to do was to capture all the patients that had been treated with Rituxan-based therapy and to see how their response equated to how long you could keep those patients in remission. And when we looked at the stratification of these patients, what we saw here was exactly what we had predicted from all the other trials, that the deeper the remission, if you can get patients into complete remission, this especially was good in keeping the patients in the longest period of time in response, followed by what we call VGPR. This is very good partial response, which represents a 90% reduction in disease burden. And then you saw PR, which is partial response, it's 50%, MR, which is minor response, 25% decrease. You get the point, that the deeper the remission, the longer it's going to last. And that's why when you try to make a cogent argument about getting patients into complete remissions, it translates into how long we can keep patients in those remissions. But here and now becomes perhaps the argument for why this isn't, in and of itself, the end-all. And that is that we can certainly take a lot of chemotherapies and bundle them together and really hit our patients hard, but with this, as you would expect, comes sometimes some very important toxicity. And I won't go over this slide in great detail, except to say that the toxicity that we fear the most is the one of secondary malignancies. And many of the drugs over the years that we've worked on, drugs like fludarabine, maybe to lesser extent a drug like bendamustine, this has been one of the consequences. So we've learned from these lessons, one being avoidance, to try to avoid these drugs, particularly in younger patients. Now you may ask me, what is a younger patient? Anybody younger than the oncologist usually is younger. And as we all get older, that benefits everyone in this room. Especially if you have Bob Kyle as your oncologist. So this policy of trying to avoid these toxic drugs, even minimize them, and I think Mort Coleman, for me, was really one of my inspirations with the drug fludarabine. He taught us very early on, you can get away with 4, you don't need to give 6 cycles of therapy. That was a very important lesson because we do see sustained activity with fludarabine if we give less. We do see even with bendamustine that if we give 4 cycles, we can do just as well as giving 6 cycles. And as a result, with this, we're being able to reduce the risk of these secondary cancers. But there are also other problems associated with many of these drugs. With bortezomib or Velcade, we see these neuropathies. Sometimes these neuropathies are reversible, sometimes they're not. Even a drug like Rituxan can actually erode away at the immune system. And over time, the patients can have recurring sinus and bronchial infections. So you see here that just merely trying to put things together and throw them at the patient in hopes of getting a complete remission isn't necessarily going to get us to the end line if we're creating other problems along the way. And that's why it's important to keep in mind that these debates are genuine and we still need answers for them. Now, a very pivotal moment in the history of Waldenstroms was the discovery of the MYD88 mutation. This is a mutation which you've heard from Dr. Hunter and others here, is present in 93 to 97% of all patients with Waldenstroms. We have to give great credit to both the IWMF as well as to Peter being a physician who made the funding possible for this study. This was done at a time that whole genome sequencing was still a very, very young art. Today it's like, you know, it's become kind of routine. But in its time, it wasn't just the challenge and the enormous expense of doing whole genome sequencing, but it also had to do with the informatics, having the right team set up so you can actually be able to decode all this information. And keep in mind that every cell has 3 billion DNA molecules. And in order to be able to map out the mistake, you also need to take a normal cell from that person, so another 3 billion DNA molecules, and then you match them up. And you try to proofread and see where the mistake is. And if you think about the MYD88 mutation, that's one mistake out of 3 billion DNA molecules. It's literally looking for a needle in a haystack. And I have to give great credit to both our computational information group at the Dana-Farber, as well as the genius of Zachary Hunter that made all this possible. Now, you may ask, well, what does this mutation do? Well, the first thing when you discover a mutation is to see whether or not it's truly functionable. And then if you decide that it is functionable, then the next thing is to see if it's actionable, meaning can I do something about it? And this was a very important slide which was published in the New England Journal of Medicine. It was a paper that actually followed the work of Lou Stout that had also found this mutation in diffuse large B-cell lymphoma in about 29% of those patients. And we all came to the same conclusion, and that is that when you have this mutation, it turns on this signaling for this survival pathway called NF-kappa B. Now, anyone in the cancer business would, the moment they hear that NF-kappa B is turned on, know right away that this is not a good thing, because this is a very powerful signal that turns on the growth and survival of these cells. And it may be a little bit hard to look at, but these little blue entities that you're seeing are all the nuclei of Waldenstroms cells. And inside those, you see the little green lights that are turned on. That's actually NF-kappa B in the nucleus turning on all the machinery so that cell can grow. And right next to what you see is those same cells now being exposed to a MYD88 inhibitor. And you see, in fact, that the lights have been turned off, and these cells are actually dying. And that's what we've been trying to do all along here with the help of the IWMF and the LLS, to be able to chart out this pathway. How are these lights turned on? What are the switches? And how can we actually disable those? And that's really where a lot of our success in being able to create the next generation of drugs has come from. Let me actually just show you what some of this entails. And this story is getting complicated by the minute. And that's good. We want complication because it just tells us about more targets. But the first paper that came out because of this, the hard work of this gentleman here, Guang Yang. He actually began to look at the pathway. And what he found was that normally this is a pathway that bacteria and viruses trigger that actually turns on the MYD88 molecule. So you need these viruses and bacteria to be able to stimulate these immune cells to grow in the normal sense. But if you acquire the mutation, the switch is turned on and it's broken. You no longer need a stimulation from the outside. Internally, the switch has been turned on. And the thing that he discovered was that Bruton's tyrosine kinase, this is the target of Ibrutinib, and you'll be hearing about other drugs like acalabrutinib and zanubrutinib target this molecule. This becomes part of the MYD88 complex. And when it's actually brought into the complex, it's able to turn on NF-kappa B, and that is what Dr. Yang was able to show us. And that became really the pivotal moment of identifying our first drug, which was Ibrutinib, as a as a way of being able to silence this pathway. And along the lines, actually, we learned another very important lesson because of Zachary Hunter, but also because of Maria Luisa Guerrera here, who was on loan to us from the University of Pavia. And they made a very interesting observation, and that is that when you have a mutation in a molecule like MYD88, it turns on the signaling. But normally, every cell has a break for all these signals. You can imagine that, the minute you turn on a switch, you're in trouble. And that's what usually happens in all of our immune cells. But you also have things that come in and shut things down. And the problem was, as they discovered, that because of other mutations, other losses, particularly in chromosome 6, that these brakes were taken out. So now you have a car with the accelerator fully pressed down, and somebody just yanked all the brakes. And in fact, if you look at some of these molecules, like the inhibitor of BTK, it's missing in about 60 to 70% of patients with Waldenstroms. If you look at some of these downstream protein inhibitors that include these molecules, HIVB2 and TNF-AIP3, they're also found in the same neighborhood of chromosome 6. They're missing in another 60 to 70% of patients. So these brakes have been yanked out. Now, just when you think, you've got the whole story here, Dr. Yang calls you into his office and says, you know what, I made another very interesting observation. And this actually is a very interesting observation because it opens up even more opportunities for treatments, but at the same time, it also tells us about why other signaling pathways are also turned on in Waldenstrom. And so what he discovered and published in the journal Blood is that when you have the mutated MYD88 molecule, it turns on this other behemoth. This is called HCK, and this is something we should all become familiar with because the IWMF as well as the LLS has provided funding to create drugs to shut down HCK. Now, what HCK does is normally it shouldn't be there in Waldenstroms cells. This is a molecule that's normally expressed in very early B cells. We're dealing with late B cells when we think about Waldenstroms, so it has no business being there. But it's the mutated MYD88 that's brought it up. It's revived it, and it's a troublemaker. And what this troublemaker does is it actually is what turns on BTK, but it also turns on these other pathways like ERK as well as AKT. We're going to talk a lot more about ERK, but these are also growth and survival pathways, and they help explain why many before us, like Irene Gobriel and Xavier Lelou and others, had found that these pathways were turned on, but they had no explanation. And what Dr. Yang, showed us is, in fact, that it's HCK being brought back to life that's turning on these other very important pathways. Now, you may say, well, what does that mean to me as a patient? Well, this is interesting because Ibrutinib not only goes after BTK, but it's also able to target HCK and shut it down. And so this is why we begin to theorize that Ibrutinib was going to be a very active drug in the treatment of Waldenstroms, and of course other BTK inhibitors, like I mentioned, were to follow. Now, Dr. Hunter spoke to you about CXCR4 mutations. We should give him complete credit for the discovery of this mutation. When we did our original whole genome screen, through our informatics group and through Dr. Hunter, this was missed. And because of his informatic prowess, his ability to go back and create whole new programs to be able to look for other mutations from the whole genome project, he was able to make this discovery. And why we should really be excited is because these are relatively unique to Waldenstroms, and they're found in up to 40% of Waldenstroms patients. There are patients who are born with defects very similar to this, but in no other cancer do you see that these molecules are expressed the way they are in Waldenstroms. Now, you may say, well, what does this mean, to me? Well, first of all, there are a lot of these mutations, and they're all clustered right here. This is a little pigtail for the protein. Normally, this is a receptor, and it signals, and I'll show you that in a second, but just keep in mind that all these mutations are clustered in this little pigtail. And what was discovered because of work that was done in our laboratory as well as in Dr. Gobriel's laboratory was that there's this molecule called CXCL12 that's turned that's secreted by the bone marrow itself. And it actually binds to CXCR4, CXCR4 being a receptor on the cell surface. And when you have the mutation, this antenna stays on, and it's able to continuously signal and turn on all these pathways, and the consequences of which are that they can actually make the cell resistant to many drugs, including the drug Ibrutinib. And so it was really important to be able to understand the context of this mutation to see its function, and then we'll talk a little bit about action that potentially can be taken against this mutation. Now, with this all in mind, we were very eager to test Ibrutinib in patients with relapsed and refractory Waldenstroms disease. I want to give credit to Dr. Advani as well as Dr. Palumba, Advani at Stanford and Palumba at Memorial Sloan, for helping to get this study off the ground. And as part of the study, the patients got 420 milligrams a day of Ibrutinib, and they could stay on the drug. And as part of the study, they also had their MYD88 and CXCR4 mutation status checked. Now, the genomic data, the signaling data, the functional data, as well as the early data of the trial, and then the whole trial being mature enough, this allowed us to get the first ever breakthrough designation by the FDA for a fast track approval. First ever in oncology, if you think about that. There's another first, that we should talk about. But where you really want the applause is the first drug approval ever for Waldenstroms macroglobulinemia. And so this is a home run, if you think about it. There isn't any cancer researcher out there who would not like to discover something in the genome, do the modeling in the laboratory, take it to the patients in a clinical trial, and ultimately get a drug approval. And why I think this is a very important story, and one that we tell all our colleagues all over the world, is that because it's within each one of us as cancer investigators to do this. We don't need large companies to be able to come to us and say, I've got a clinical trial for you. We can actually do the discovery. And that's what, Carl, you were able to do for this field. You've been able to enable, because of all the funding, this kind of discovery from the ground up. And this success story, you should all be, you and whoever else is listening out there across the world, should be extremely proud, because this is just the first chapter of many that I think are going to be written because of everything that we learned from the whole genome. Now, I want to update you a little bit with the trial results. The final summary of these results is going to be presented at the International Conference on Malignant Lymphoma in just 2 weeks' time. But I just wanted to give you a little glimpse about what we've learned up to now. And of course, that data will be presented for the first time in Lugano in Switzerland at that meeting. So initially, when the study was published in the New England Journal of Medicine, we only had about 19 months average follow-up for all the patients. The data that we reported subsequent to that was 47 months, so almost 4 years follow-up. And the last patient follow-up was in October of this past year. Now, if you look here, the overall response rate, that means any of those response categories that I showed you earlier, was 91%. 78% of the patients had what we call a major response, at least a partial 50% reduction. And VGPR, which is very good partial response, was 29%. What you don't see here is, again, complete response, okay? And that's really the sobering part of this data. But on the other hand, what you also see, which I think is a very important learning curve, is how the mutations made a difference. If you had no MYD88 mutation, you really didn't get deep responses. If you did have a MYD88 mutation plus CXCR4, you were double mutated, you see, in fact, the deeper responses were elusive. We only saw 10% of the VGPRs if you had both mutations, 44% if you only had the MYD88 mutation. And it took you longer to get there. It took you 6 months if you had the CXCR4 mutation. It took you only 2 months if you didn't. So this begins to frame to us why the genomics is so important. So when many of you ask the question, should I be getting this mutation screen done, this is where it can be factored in to clinical decision making. Now, this is also a very important slide because it shows you how patients fared on this study over time. So at 5 years after commencing therapy, 60% of all the patients are still in a remission. And that's really important to keep in mind because these were all heavily pretreated patients. Some people had up to 9 prior therapies before coming on this study. And when one thinks about, what comes after number 9, there's really not much. But yet those patients, also benefited by the Ibrutinib. But what you also see now is the breakdown of how long patients remained in a remission. If you had only the MYD88 mutation, 3/4, 75% of those patients are still in a remission at 5 years. If you had both, it's somewhere around 50 months, which is still extraordinary when you think about all the other therapeutics, the benchmarks that we compare to. And if you had no MYD88 mutation, the disease progressed very quickly. We also learned the same thing from our frontline study. We did a study in patients that had not been treated previously that were receiving Ibrutinib for the first time. There's my colleague Jorge Castillo, who has been navigating this study. It was published as the JCO editor's pick. I just want you to hear that. This is the top oncology journal in the world, and yet Waldenstroms was the editor's pick for that particular issue. And that was because not only of the activity with Ibrutinib, but the genomic data. And it was almost a copy of what we had learned from the previously treated patients, that if you had both mutations, you didn't get those deep responses and it took longer to get there. Now, one very important study that was an outcome of the BTK discovery was the Innovate study. In fact, I do know in this room that we have some Innovate participants. This was a very large randomized study, 150 patients who took part in the study, 45 centers in 9 countries. And the objective of this study was to see how patients did if they got Ibrutinib plus Rituxan versus what had been deemed the community standard of Rituxan alone. The data that I want to show you here is very interesting because what we learned in those studies with Ibrutinib alone came to be that if you had both mutations, that those deep responses were less. You see 73% versus 94% if you had only the MYD88 mutation. And with this, if you look at once again how long those responses lasted, what do you see here? You see, in fact, that those individuals that had the CXCR4 mutation progressed earlier. So once again, very much in line, despite this being a very large clinical trial, seeing the same observation. So you see where now CXCR4 itself has also a role in preventing us from getting at those complete responses and keeping patients even in deep responses. Now, can we do something about it? We talked about function. Now it's time for action. And I will tell you that the results of this particular trial are very, very promising, and they actually help validate that we can go after CXCR4. This is a trial using the drug Yolo. It took me a long time to be able to learn how to pronounce it. And I think Jorge Castillo did it very nicely with his Latin American accent, so I started taking after him. But Yolo is an antibody that actually binds to CXCR4, and it prevents that CXCL12 that's released from the bone marrow from engaging its receptor. So you can actually turn off CXCR4 with this antibody. This has been a phase 1 study where we're giving lower dose of the drug, and then we're going up with time. And we are now into cohort 3. We've done well with cohort 1. We've gotten through cohort 2 well. Now we're into cohort 3. And the patients are getting 6 months of the drug. And what we're seeing is very rapidly they're getting into those deep remissions. We're not waiting now 6 or 7 months. And we're also seeing that those remissions are deeper. Now there is a successor to this drug, which is an oral inhibitor. X4 is the company that's making it. We're very excited that they're actually looking at Waldenstroms as a disease where they want to be able to bring their oral inhibitor against CXCR4 into a clinical trial. So I think as far as the news to share with you, which is really very important news, we now have a second actionable mutation in Waldenstroms. And I think this is going to be a very, very exciting area for further discovery and maybe really, in a few years' time, once we have all that data, to change our standard of care. Now, the next slide shows that we're going to get even more complicated, because it shows you that Dr. Yang in the laboratory can be very dangerous. He can find more problems. But at the same time, what Dr. Yang is able to do that very few other people do, he can also find solutions. And with his graduate student here, Dr. Maneet Munshi, they've been able to now discover that MYD88 also causes one more thing to be turned on, and that's this molecule called SEEK. For many years now, work that was done largely at Memorial Sloan by Leah Palumbo, we knew that this other pathway was turned on in Waldenstroms, but we really didn't know what was causing it. And that's what actually stimulated Dr. Yang to look, for additional contributors to MYD88 signaling. This here pathway, called the BCR pathway, is turned on in patients with Waldenstroms. And it's because MYD88 is able to turn on this molecule SEEK that occurs. Now look what happens downstream. You see the molecule STAT3. Many years ago, Dr. Ansel told us that STAT3 was actually turned on in Waldenstroms, but we didn't know why. We also knew that the molecule AKT was turned on for reasons that I mentioned earlier, because of work by Irene Gobriel and Xavier Lelou, again, not knowing why. But now we do. We understand that MYD88 is able to turn on this very important pathway. And you may ask now, well, what does that mean? Well, what it means is that if you're treating somebody with Ibrutinib and you're able to block, parts of the pathway, you still have a signaling pathway that still remains on, that keeps those cells alive and well. And that's where, once again, I think the fortitude of the IWMF and the LLS have played a very important role. Because one of the drugs that they've helped us develop, which is this drug called KIN 8194, not only is able to inhibit HCK and BTK, but it also takes out the molecule that turns on SEEK in the downstream pathway. And this is very exciting because this molecule continues to advance, and I hope one day, very, very soon, will complete its toxicology and be able to get into the clinic. But we're very excited about this molecule. And again, if you want to think about what happens with the grant money that you provide us with, this is it. We're able to bring together lots of very bright people with different levels of expertise. In this case, it was bringing together the Harvard Medicinal Chemistry group, giving them the targets, and letting them work with our group to be able to develop these drugs. Now, I'm going to tell you about another very important problem in Waldenstroms, and it has to do with this molecule called Bcl II. I think Dr. Hunter had already talked about this. I know Dr. Castillo also mentioned this to you. But fundamentally, whenever you're dealing with these type of cells, B cells, you may be able to kick them really hard, but they won't die, because they have internal programming that turns on that prevents them from turning on the switches of self-destruct. And Bcl II is one of those very, very important molecules. It's very highly expressed, especially in people that have the MYD88 mutation. As a result, you can kick very hard, but you're not going to get these cells to die. And as a result, what we have been trying to do is to be able to stop, Bcl II in order to get these cells to die. Now, if you need an example, it's like going to a very aggressive soccer game where you've got the Ibrutinib team, or Zanubrutinib, or Acalabrutinib, all trying to score. And what you have is the goalie there, representing Bcl II, that's trying to block that from happening. For my Canadian friends, I would have put a hockey game in here, but I know how, on the edge we are these days with the Bruins in on this, so I figured we would just limit it to a soccer game this time. But this really frames the problem, that if we're going to make any strides, we need to take out Bcl II. Now, very early on, before many people even had heard about the drug Venetoclax, Dr. Yang Kao in our laboratory was already working with this molecule, and she made a very interesting discovery. She used cell lines that were both CXCR4 normal and CXCR4 mutated. And what she showed here was that if she added Ibrutinib, she got a little whiff of death. She measured these bands here which are bands that predict that the cell is undergoing apoptosis or cell death. She added in the drug ABT199. That's actually the drug Venetoclax. The same thing. She saw a little whiff of, cell killing. And then she added both drugs together, and you can see how potently the cell death mechanism was induced. And this was the same whether or not she was dealing with CXCR4 normal or CXCR4 mutated cells. And along comes another very important hero of mine, Jorge Castillo, and runs this very important trial now looking at the activity of Venetoclax in Waldenstroms patients that had already been treated. And this was a very important trial because it taught us that Venetoclax was active in previously treated Waldenstroms patients, regardless of whether they had had Ibrutinib before or their CXCR4 mutation status. But again, if you look at those deep responses, it was better if you hadn't seen Ibrutinib. It was better if you had not the CXCR4 mutation. Now, what I think is going to turn out to be probably one of the most exciting trials going ahead is this combination study of Ibrutinib and Venetoclax, because if it's true to what we've seen in culture, in our preclinical studies, this study will have perhaps the greatest ability to deliver on those deeper responses, and hopefully some of them ultimately leading to eradication of disease. So in the next couple of slides, I want to show you some of the most exciting work that's going on at the Bing Center. And it speaks to another very important problem, and that is drug resistance. Ibrutinib has been a very successful drug, but whether it's using it in Waldenstroms, using it in CLL, mantle cell lymphoma, marginal zone lymphoma, even the aggressive lymphomas, we're starting to see resistance. And this occurs for some patients within a few years' time, for some perhaps later on. And this has to do with this mutation in Bruton's tyrosine kinase itself. So the mutation occurs where the Ibrutinib is supposed to bind to BTK. And as a result, Ibrutinib no longer can bind and inactivate this very, very critical protein. And in some patients, as Leanne Zhu in our group showed, some patients can actually have multiple different types of BTK mutations. So it shows you that this is a very important pathway, and that when these cells break through, they break through on different fronts. Most of these patients also tend to be people that have the CXCR4 mutation, and reasons why we see this as an underlying generator of these mutations remains to be seen. Now, in our laboratory, we've had the great fortune of having this mother and son team, the Chens, you can see the resemblance there, working very diligently on trying to understand what these mutations do. And this is actually a first for the entire field, because very few people have cell lines like we do in Waldenstroms. There are no cell lines in CLL. We have them in Waldenstroms. So we're actually able to put these mutations into the cells and then study what they do. And what we found was they actually turn on this pathway ERK. Didn't we talk about ERK earlier? And ERK itself gets turned on because of the mutation. And as a result, it's able to keep these cells alive and unable to be killed because of Ibrutinib. Now, what these cells also do is they start corrupting all the good cells around them. It's almost as if you've got now one spoiled apple now ruining the whole bushel. And that's what these cells are doing. And as a result, we've been focused on ways to be able to get rid of this very bad apple. So let me show you the experiment that actually got a lot of notoriety, funded by the IWMF. This was an experiment where on one side of this culture dish, we put the bad apples, or we put the good apples. And then we wanted to see what happened on the other side in the presence of Ibrutinib. And what happened is that if you had good cells on one side, no mutation, and you added Ibrutinib, they all died. But if you had the bad apple, represented in red there, and you put them on one side, they also made the cells on the other side that didn't have the mutation resistant. And that's because all these cytokines, these proteins, were getting through the membrane, and they were causing those cells to resist Ibrutinib. And as a result, these cells were able to live and expand. Now, we have actually a drug made against ERK. This is, again, the pathway that's turned on. And thanks to, once again, your support, we've been able to leverage the knowledge of this new drug, this ERK inhibitor, that we're now going to be using in patients who have developed the Ibrutinib resistance gene and are progressing. And rather than take these patients off Ibrutinib, which often comes with many consequences, the intent here is to add the ERK inhibitor to be able to silence out all these bad cells in hopes of being able to continue the Ibrutinib function. And I think this is going to be a very important trial. It's not just Waldenstroms. We'll be seeing about its effect in other diseases that benefit also by Ibrutinib. Now, on the horizon, I want you to get excited about these other BTK inhibitors. There's a drug called acalabrutinib. It's also shown a lot of activity, very similar to Ibrutinib, but also the drug zanubrutinib, which is also showing very high levels of response in patients with Waldenstroms. And what I think we should all get excited about is whenever we see a phase 3 study, where we're now trying to compare, one drug against the other. And in this case, this is a study comparing zanubrutinib against Ibrutinib in Waldenstroms patients. This is a trial that's already been fully enrolled and has involved a lot of investigators across many, many countries. And this really shows you that when you get a field going, you can really start bringing a lot of very new and exciting drugs. Now, the real challenge coming out of our workshops, out of our roadmap meetings, is that we now have a lot of partners that we can use to be able to eradicate residual or resistant disease. And you can see here that it's not just limited to therapies that we can give to patients in combination with Ibrutinib, but also involves other immunotherapies that can be used to help get rid of these residual resistant cells. And it's really being able to incorporate all these novel therapies that really represents all the excitement for the next chapter in Waldenstroms. In the last couple of slides, I just also want to touch bases on a few other areas that are very important that we should all be thinking about. Not everyone has the MYD88 mutation. There's approximately, anywhere between 3 and 10% of patients who don't. And this is a very important unmet need because these patients don't benefit with Ibrutinib, and even other therapeutics that we have seen, such as the recent bendamustine trial by the French, also show that these are the patients that fall out, very, very early. Now, what does this mean in terms of, outcome? This is actually a survival curve. Now, normally, I don't show survival curves, particularly at a meeting like this. But I'm going to show you a survival curve because the first piece of good news that I want to show you on the survival curve, this came from the Bing Center patient population, is that when you look at average overall survival in those patients that have the MYD88 mutation, regardless of CXCR4, it's over 18 years now. So think about where we were and where we are now and where we're going, more importantly. But I want you to also see that in this chart, these are the patients that don't have the MYD88 mutation. And this is why we still have to focus very importantly on this population. And one of the reasons why these patients don't do as well is because they tend to transform to more aggressive lymphomas. This was based on a study we did as well as our colleagues at the Mayo, calling out that these patients actually have a higher risk of transforming to a more aggressive lymphoma. So at our group, Zach Hunter has been very focused, along with his group, to try to identify the mutations that underlie the driver of this particular disease. We actually were able to identify very important mutations, including some highly recurrent ones, and even ones that I think we're going to get, to be able to make targeted therapies. But in this gene list were also genes that also are found in aggressive lymphomas. So right away we knew why we had this transformation problem. We also were able to model this in existing signaling cascades that we knew, to also understand that most of these mutations that drive this disease are below BTK. So as a result, even if you give the Ibrutinib, these things are under the BTK protein, and as a result, that's why we're not seeing the benefit. And so this is really, I think, a very important challenge, Carl, as we go ahead, and Tom, to be able to try to better understand and target this patient population. Now, you've heard about MYD88, you've heard about CXCR4. Many of you are going to go to bed tonight thinking these are the only two things I need to worry about. Not true. Or at least you may not worry about them. I have to tomorrow. Yeah. So are there other mutations? The answer is yes. And some of these other mutations, actually based on our very short, small whole genome sequencing effort, we're still coming out between 5 and 20%. So there's all these other mutations we do need to worry about. And why we need to worry about them is because they potentially give us also actionable mutations. In fact, some of them on this list are things that we actually can have drugs already on the shelf today that we can actually take to the clinic and start looking at. So with your help from the IWMF, you've helped us fund the 300 project. This is a very interesting project, and it's almost on the same scale as any other large lymphoma sequencing that has been done. In fact, when you see the two papers by Dr. Stout's group at the NIH and you look at Dr. Ship's group from the Dana-Farber on aggressive lymphomas, the largest ever sequencing effort, there were only 300 patients. And here we are now with a far less common Waldenstroms, and we're there as well. And what this project is really meant to do is to look at Waldenstroms almost like layers of cake, looking at the DNA, RNA, and everything else on top of that that helps regulate the DNA. And this is going to give us a very comprehensive atlas. So if we're ever going to dream about personalized medicine approach, this is the project that I think is really going to help us the most, because then we'll be able to chart a course that has to do with every individual's own genomic problems. Now, before you get too excited, also think about one other problem, and that is these genomic mistakes are also a moving target. And our myeloma colleagues have taught us this because they've had a little bit of advance, on us, because they've also seen that when they expose patients to certain drugs, their disease and their mutations also evolve over time. And this, too, turned out to be one of the important things at the roadmap meeting that we really need to invest in, to try to see what happens to the evolution of these clones over time with different therapeutics. Now, Tom already let out the cat on the, out of the bag on this one, and that is, do you want us to be able to find MYD88 in a much easier way than bone marrow biopsies? You got to be louder. I want everyone outside of here to hear you. This is really important, because if we're going to do any type of personalized medicine, we got to get it right. A lot of these testing platforms that we use can miss the MYD88, mutation. And you've got now clinical trials that are reporting activity, in patients that don't have the MYD88 mutation, as an example. And you have to ask, is this real? Because there are fundamental problems. One is that if you're relying on the peripheral blood to be able to check for the mutation, it works. But you've got to do it when the patient hasn't seen any therapy. If they have, it's going to be hard. The other is the platform that you're using. If you're relying on what most people in most clinical diagnostic laboratories do, which is this next generation type of sequencing, you can miss, up to 30% of patients compared to the gold standard of PCR. And so as a result, there's a lot of real interest. Dr. Drandy has published just very recently a very nice paper from Italy on the use of cell-free DNA, where you just take the DNA out of the blood and check for it. And this has the ability of capturing MYD88 no matter where it is, whether it's in the bone marrow and lymph nodes. And so as a result, I really do think this is going to be a very important area for us to fund because MYD88 is so critical. And I think also CXCR4 testing will also be a great beneficiary. And when it comes to CXCR4, the actual mutations that we care about, what we call the nonsense mutations, Dr. Castillo published a very nice paper having to do with these mutations, these nonsense mutations that can be easily picked up, on these screens as being the ones that we should care about the most when it comes to thinking about, the use of Ibrutinib. And that's why, once again, these represent actionable mutations that we ought to, get to know more about. In coming to a conclusion here, I just want to talk about two other areas that I think we all need to care more about, and that is first the patients with Bing-Nail syndrome. We all acknowledge that this represents a very severe morbidity, and up to very recent times, we've been kind of going at this very much ad hoc. We do know because of some limited data that Ibrutinib, particularly at higher doses, may be effective, but also, as you can see, there are other drugs, but we have no prospective trials, and that's something that I really urge the field, to look at. We need to be able to, as advocates in this room, to be able to advocate for these trials because these are patients that need our help. And this goes to show you in this slide that we can make a difference. This is a patient that had probably one of the worst cases of Bing-Neill syndrome who got high-dose Ibrutinib, and just a few months later, his disease had cleared out. And simultaneously, this patient had the drug levels of Ibrutinib checked in both his CSF that circulates in the brain as well as his blood to show, in fact, that the drug was getting through. So this is why these kind of trials are very, very important. And peripheral neuropathy. I'm sure there are people in this room that are here because of peripheral neuropathy. Again, we've had no dedicated trial against peripheral neuropathy in Waldenstroms, despite the fact that almost a quarter of all patients come in because of peripheral neuropathy. And that's a very important area because all the existing modalities that we use are not really doing anything more than slowing things down. They're not getting us to resolution of these neuropathies. And so as a result, as Dr. Nobile Orazio's study showed us, if we're not able to control neuropathy over time, patients can become disabled. And so this is why drugs like Ibrutinib that have shown activity against peripheral neuropathy, need to now be tested in a prospective manner for us to be able to find, new and validated ways of treating this particular morbidity. I just want to close here by showing you a couple of pictures from the international workshop. This is actually one of the sessions. Again, 350 investigators representing 35 countries. It was wonderful to see everybody coming together in New York to talk about all this subject matter that we just kind of went over today over the 3.5 days' time. And at the meeting, we honored Dr. Giampaolo Merlini with the Robert A. Kyle Award, as well as Bart Barloghi with the Jan Waldenstrom Award. These are both individuals that have made tremendous contributions to our field. And of course, we had the opportunity also honor 4 humanitarians at a ceremony that took place at the United Nations. And these were people that I think many of you already know. It includes Mort Coleman, who's here with us. In fact, we have 3 of these individuals here today, honoring them for all their humanitarian efforts in Waldenstroms. Carl Harrington, who I know all of you know. Chris Patterson. And of course, somebody that we all need to acknowledge as well, and that's Ranjan Advani, who actually ran the first Ibrutinib trial that included Waldenstrom's patients. And the last actually is my favorite, and this is really the hope that we have for the future. These are all the young investigators, 20 of them, that we were able to honor. These were all individuals who submitted their scientific work in abstracts, and they were chosen to be acknowledged with their awards, and this took place on Ellis Island. And I think if there's one thing to talk about here and get excited about is the legacy that we're now imparting for this disease, not only attracting people from all over the world, but creating a whole new generation to keep fighting. Thank you so much for your kind attention, and let's keep up the good work. Thank you.
Thank you, Dr. Treon. That was just outstanding. What we're going to do now is we got about 10 minutes for questions, and rather than run them around, do you think you can make your way up here if you got questions? We'll have Sue over here and Michael over there with a microphone. And if you can wind your way through the tables.